All right, welcome everyone. Let's give it a few more moments for other folks to join us, and then we'll get started. All right, so I'm not seeing anyone else jumping into the waiting room. So Dan, I'll hand it over to you.
Okay. Well, welcome all to Child Rights Introductory Webinar and Discussion on Strategies for Increasing Equitable Impact. I'm attending virtually, as you can see from the slide, from Vancouver, where in most days I'm grateful to live, work, and play on the unceded traditional territory that have been shepherded by the Musqueam, Squamish, and Tsleil-Waututh nations over the centuries. I came to Canada as a settler some 15 years ago from a land to the south that was and still is being ripped apart by a history of colonization and oppression. But in coming to what I thought was a more idyllic place, that is Canada, I found that we have our own racist past, but are dealing with this past in a way that I believe is demonstrating to a world leadership in this regard. And these introductory acknowledgements are an important step in this pathway. With this land acknowledgement, we're recognizing the appropriations of the past and the colonial treatment of Indigenous tribes in Canada. One hugely dehumanizing aspect of the racialized policies of governments around the world, but a very recent terrible history in Canada is that of the residential school, a direct antecedent to the very sorry state of Indigenous children in the child welfare system today. This shameful sidelining of human potential has also been shared by children and youth with neurodevelopmental conditions, as recently documented in a film about Ontario's Huronia Regional Centre by Barry Cohen. I recommend everyone see this film entitled Unloved, Huronia's Forgotten Children. Both of these issues, that is a child welfare system and the treatment of kids with neurodevelopmental disabilities, are central to child right and moving forward and helping society to right these wrongs and provide the mobilization of knowledge and implementation science approaches to right these wrongs relative to brain health. And we hope that what emerges from today's session is a sort of a discussion where we can recognize and dismantle colonial ways of thinking and create in its place an equitable, diverse, anti-racist, and indigenized network and nation. And with those initial comments, I'd like to turn it to the co-lead of the training component of Child Right, Celia Lohr, to take us into this session.
Right, thank you, Dan. Yes, so I am Celia. I am the co-lead for the Child Rights Network, having joined fairly recently with this group. And in my other role, I'm a researcher in implementation science at Women's College Hospital. And what we were hoping to be able to do today was to provide a really broad introduction to some of the core concepts of implementation science, knowledge mobilization, equity, diversity, and inclusion, and keeping in mind those pieces that Dan was talking about in that land acknowledgement, to be able to think about how do we consider that in the work that we do regarding patient-oriented research and these additional topics that are some of the way to bridge that gap between the research and the practice and the ways to be able to support people. So for these topics, we're going to be looking very broadly at what does it mean when we say implementation science? What does it mean when we start to talk about knowledge mobilization? And how do we think about these pieces together and the way that they can be quite complementary? And we recognize that these are all very big topics, and you're probably going to have a lot of questions based on just getting a little bit of a snapshot and from your own experiences as well, which is why we've put a large portion of this presentation. The last half hour is actually entirely dedicated to questions and answers from all of you. So thinking about them, feel free to put them in the chat, and we can get to them at the end, but also feel welcome to think about any of the broader questions that you have been thinking about related to these subjects, and hopefully we can have a bit of a discussion around that at the end. So for just a little bit of housekeeping before we get started, please remember to mute your microphone. Hopefully there isn't too much background noise for the speakers. We are suggesting that people keep their cameras off during the presentations, but also feel welcome and really encourage you to turn them back on during the Q&A so we can have that more interactive sense, particularly while we are all virtual. And feel free to put your ideas, your comments, your questions in the chat. People can feel free to respond and interact that way, and we'll be able to go through some of those in a bit more detail at the end in that Q&A session. So I believe it is my privilege to be able to welcome our three speakers today. So Janet Curran, Stephanie Glegg, and Noah Delamy, who will be joining us today to provide those brief introductions to these subjects, and I'll bring in for the panel discussion at the end. So first, we'd like to welcome Janet Curran, who can put up her slides. So Dr. Curran is a professor in the School of Nursing at Dalhousie University and a clinician scientist at the IWK Health Center. So welcome.
Sorry, I was looking for my mute button. Celia, are you able to see my slides?
Yes, you're good.
So, good morning or good afternoon, depending on the coast you're sitting on right now. My name is Janet Curran, and I'm a research chair in quality improvement and patient safety in Nova Scotia, and a lifelong learner in implementation science. I have no conflicts of interest to declare, but I would like to begin by acknowledging that I'm speaking with you today from Halifax, Nova Scotia, which is situated in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which Mi'kma'ki and the Maliseet people first signed with the British Crown in 1725. Over the next 15 minutes, I will provide you with a very high level of what is implementation science and why is it important. I will share some of the challenges that I see facing the field, as well as some opportunities. So what is all the hype about implementation science? Well, to begin, significant funding and resources from organizational, provincial, federal, and international sources is committed to clinical and health system research every year, and many of us on this call have benefited from that funding. This research is producing new findings that, if implemented, could contribute to effective and efficient patient care and health system change. However, this can only happen if health professionals and health systems first adopt these research findings. I am sure many of you have heard the statistic regarding the lag between evidence production and evidence adoption in practice. That's 17 years. More importantly, we are also seeing consistent evidence that patients are not receiving care that is supported by evidence. Janet Squires and colleagues recently published a systematic review reporting on inappropriately used clinical practices in Canada. Their review included 174 studies representing 228 clinical practices across Canada. The median proportion of inappropriate care was determined to be 30%, with underuse or patients not receiving recommended practice being more common than overuse, that is, patients receiving a practice when not recommended. When looking across the types of care, we see that both diagnostic tests, such as blood work or screening, and therapeutic practices, such as medications or physical therapy, were equally plagued by inappropriate use, both underuse and overuse of different practices. So as we can see, the movement of evidence-based practice into clinical use is less than perfect. The field of implementation science has developed to facilitate the spread of evidence into healthcare policy and practice. It is specifically focused on that gap that separates evidence produced through research and the actions, behaviors, or decisions of individuals. This is otherwise known as the no-do gap. Implementation science is a human enterprise, and the goal is to develop an empirical and theoretical basis to optimize implementation activities. Implementation science and effective implementation requires interdisciplinary and multi-sector collaboration between patients or members of the community, researchers, implementers, policymakers, clinicians, and other relevant stakeholders. So as you can see, it's not an individual researcher enterprise. However, the wide range and variability in the types of implementation problems that exist can pose a challenge to building an empirical and theoretical basis in our field of implementation science. Some of these challenges can be attributed to the types of problems, but also the types of targets of the interventions, whether that be patients or healthcare providers or policymakers, and the type of settings where these targets operate. So either hospital settings, or community settings, schools, or even patients' homes. And as you can imagine, all of this variability can influence the way in which an implementation strategy works or doesn't work. So studying implementation can be complex. There's also complexity within the academic institution, where we see a variety of terms used to express the same concept, or concepts that are poorly described or defined in the literature. So there's definitely some room for building a shared understanding and language for poorly described contexts, or sorry, poorly described terms and concepts. That said, we're also seeing guidance and standards that can help focus and strengthen the evidence base in our field. These are just a few examples of those types of supports. The Standards for Reporting Implementation Studies, or STARI initiative, aim to develop guidelines for transparent and accurate reporting of implementation studies. These were informed by the findings of a systematic review and a consensus-building Delphi exercise. An international working group of implementation science experts discussed all of that literature and came up with this 27-item checklist. The expectation is that research authors will clarify both how they anticipate the strategies that they're implementing will likely work, and they'll explain the underpinnings or the premise of why implementation of the intervention may be expected to improve healthcare or health outcomes. Another such tool is the Tidier checklist, which some of you may be familiar with. The Tidier checklist provides us with reporting details of intervention elements and, where relevant, comparison elements that are included in studies. So it provides guidance on how we should be describing those interventions. I had listed two other potential sources that may be of help to you. That is a taxonomy of implementation outcomes, which would guide us towards how we should be describing and collecting data on particular outcomes that are of interest to implementation science, as well as the ERIC taxonomy for recommendations for implementing intervention change. So what we know is that enhancing the uptake of evidence at an individual or system level generally involves some type of change. And designing these interventions to facilitate change starts with a thorough analysis of a problem, including identifying who needs to do what differently. Colquhoun and colleagues completed a systematic review of published methods to change healthcare provider behaviors and identified that most methods were grounded in theory and included a formal assessment of barriers and facilitators for implementing change. They used a systematic approach to select intervention components to address these behavior targets. And then what is good to know is that many of them also engaged end users in the process. So we see that there are a number of frameworks that have been published that you can use to help guide this process of designing interventions. There is support guidance that has been published in this reference that you see on my slide from Moulin, in which they provide you with a checklist to help you identify which framework might be useful for the type of study that you're undertaking. I also think it's important in this overview to give a shout out to context. Context is often considered responsible for between study variations in implementation outcomes. So understanding what happens when an evidence-based practice is implemented with a specific team, department, or organization is important. Accounting for the influence of context is needed to help explain how and why certain implementation outcomes are achieved. In 2019, Nielsen conducted a scoping review to map the dimensions of context used in determinant frameworks in implementation science literature. Determinant frameworks are frameworks which have a descriptive purpose by pointing to factors believed or found to influence implementation outcomes. And although there was variation in the terms used to describe dimensions of context, it was possible to identify the common dimensions influencing implementing outcomes. And these are organizational support, financial resources, social relations and support, leadership, organization culture and climate, and organizational readiness to change. Complex interventions are commonly used to facilitate change in health and social care services, public health practice, and other areas of social and economic policy. I'm sharing with you here one framework as an example of how one might plan the research. The framework for developing and evaluating complex interventions aims to help researchers work with other stakeholders to identify the key questions about complex interventions and to design and conduct research with a diversity of perspectives and appropriate choice of methods. The framework divides the research into 4 phases that you can see in purple here. These are development or identification of an intervention, feasibility testing, evaluation, and implementation. And at each of these phases, the 6 core elements that are in red in the central core of this should be considered to answer these questions. How does the intervention interact with the context? What is the underpinning program theory or the theoretical framework that's underpinning your work? How can diverse stakeholder perspectives be included in this research? What are the key uncertainties? How can the intervention be refined? And what are the comparative resources and outcome consequences of this intervention? And the answers of these questions should be used to decide whether the research should proceed to the next phase, return to the previous phase, repeat the phase, or stop. So in summary, the evidence of implementation science is on understanding how and why interventions work. Implementation research should be grounded in theory to assist with building a generalizable knowledge base. There is a substantive evidence base on the effects of different implementation interventions, and there is an evolving evidence base for healthcare systems. So this is a base that we can use to build our knowledge in our field in child right. Future evaluative efforts need to focus on more transparent intervention development, more creative designs, and better reporting to enhance the informativeness of our implementation studies. Thank you.
All right, so thank you, Janet. That was always great to hear about some of those introductions and the complexity within implementation science. So there's already, I'm sure, lots of questions about that. So now I'd like to welcome Stephanie Gleig, who is a postdoctoral fellow at the University of British Columbia and a pediatric occupational therapist at the Sunny Hill Center for Children. So thank you.
Hello, everybody. Just getting my slide deck up for you.
You're in presentation mode if you're.
Right.
There you go, perfect.
Great, so thank you for the introduction. I am an implementation scientist and I'm also a knowledge mobilization practitioner. So I'm going to be speaking about the latter since Janet provided a great introduction to implementation science for us all. I am joining today from the traditional unceded homelands of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh peoples. I am uninvited on these lands and of settler ancestry. And through my research, I am working to and committed to help address some of the Truth and Reconciliation Commission of Canada's calls to action in my work. So today in my section, we'll be starting out with defining knowledge mobilization, and then we'll speak a little bit about the why, the what, the who, the when, and the how of KM, and then where it fits in with implementation science, with patient-oriented research, and with equity, diversity, inclusion, decolonization, and indigenization, or EDI-DI, which Noma will be addressing after me. So the definition that we're working with in the knowledge mobilization program in Child Bright is basically the activities that are involved in the co-creation of knowledge by researchers and knowledge users, and the use of research and other knowledge to improve healthcare and enhance health outcomes in a sustainable way. That sounds like a lot, but I think one of the key points here is that it happens throughout the process of coming together, generating knowledge through research, sharing the findings of the research. It's not just an end of grant kind of process. A simplified way to refer to this is moving knowledge into action. And I think it's important to note that, as Janet alluded to, there are many different terms that people use in this field, over 100 in the literature, and we use different terms to mean the same thing, and sometimes we use the same terms to mean different things. So it's important to make sure that you define what you mean when you're speaking about one of these terms, and understanding what the person you're speaking with understands that to mean, so that you're on the same page. So other words that are often used are dissemination, and sometimes people use knowledge mobilization to focus just on dissemination, which means sharing knowledge, pushing it out to others in some way. When we use it, we also mean implementation. So going from sharing knowledge, supporting people to use it in their practice, in their policy, but without that research element, although we draw heavily on implementation science to guide the work. So why do we do KM? We might be wanting to increase awareness or knowledge, and so we might use, passive methods like sharing materials about the findings of our research as an example there. We might also be wanting to influence attitudes or enhance skills, change practice or policy in healthcare. It might be as a purpose to establish partnerships or collaborations. So an example of that might be sharing about the project that you're engaged in as a means of identifying others with similar or overlapping goals that you could partner on to move the end goal forward. And there are other goals that are not listed here that will be specific to each project. But the point here would be that there are lots of different reasons why we do KM. What do you mobilize? So you might have an intervention that you would like implemented because it's shown to be effective, or a change in practice around different assessment tools being used. There might be tools or resources or best practices that are identified through research and evaluation, policy recommendations, and other even like Indigenous ways of knowing. So there are lots of different aspects of knowledge that can be mobilized, and the approaches might be different for each one and for each target audience. So what we try to do is to identify what our key messages for action are. And once you have that, then you can move forward with developing a plan for how you want to mobilize that. And you might have some knowledge, and the key message for action might be different depending on who the target knowledge user might be. So who is involved in KM? So I've included a list, an incomplete list of knowledge users, the end users of this knowledge that's being mobilized. Examples include children and youth, families or patients, healthcare providers, policymakers, healthcare leaders, community partners, teachers. You know, the list goes on, and it depends on the nature of the key message for action, the nature of the knowledge that's being shared. But knowledge mobilization doesn't happen in a vacuum. It's not something that you do to yourself on a deserted island. It's a social process, and we can also engage partners and allies in this work. So some of our partners and allies should be the knowledge users that we're trying to reach, because they understand the group, their culture, their needs, the types of messaging that they might like to receive or that might resonate best with them. But we can also engage other people, so leaders, early adopters who pick up things quickly and can be models for the spread of the use of that knowledge, champions or opinion leaders that can rally those around them or lead by example, bridgers who might connect different groups and bring new perspectives and help to break down some of those silos. Disruptors, I put that there because there might be people who are not keen on the change, and that might be a place that you target as a means of generating change. As we think about who, for KM, for knowledge users, we want to think about the people who will benefit from the research or the knowledge, and those who will be impacted by it. And then the partners and allies are those who have influence, who have resources, who might be decision makers, and allies to support the goals. The when of KM. So knowledge mobilization can happen at all stages of a project, from engagement. This is a very simplified version of, for example, a research project, but it can happen at all of these stages, and the type of knowledge that you might be mobilizing will be different at each stage. The approaches you use will be different. The people that are engaged might be different, but as a patient-oriented research network, at the heart of what we do is engaging patients, families, youth in that work from the start through the end. But it doesn't need to be limited to patient partners. If it's a healthcare intervention, you would ideally be engaging healthcare providers as well. So the how of KM. this is obviously more complicated, and I just put this together to bring a bit of cohesion to what I just talked about. These ideas are drawn from theories and frameworks, from implementation science, from knowledge translation science, and they don't have to happen in order. It will depend on if you start with your evidence, or you start with a problem, or you start with the people. So here we're basically identifying why we want to do KM, what's our end goal of this process, and we could have many goals for many different groups. And then the if, so do we need to move forward with this knowledge mobilization? So as Janet mentioned, the no-do gap, if everyone's already using the knowledge, we don't need to put effort into that to create change because it's already happening. The who is identifying the key people that need to be involved and who we're trying to reach or engage with. The what is how we're tailoring those key messages for action for those audiences. And then the how is where we look at, we can draw on theory here as well to assess the barriers and facilitators of the change that we're hoping will come from the KM activities, and then selecting KM activities based on theory, based on the evidence supporting those different KM strategies for different goals, for different groups, and factoring in the context as well. And then, as I mentioned, the when happens throughout. And the last element, which you need to plan from the start, is how well. So we would still be evaluating how did the knowledge mobilization process go, and did we achieve the outcomes that we intended to achieve? How does it intersect with implementation science? So the way I think about it is that the knowledge mobilization is the doing of dissemination and implementation, and it involves facilitation and evaluation with the aim of sharing, implementing, improving health care, health services, health systems, health outcomes. And then implementation science would be the studying of that implementation, with one end goal being advancing the science of KT to guide our future activities. Intersecting with patient-oriented research, as I mentioned, engaging those people that will be impacted by or benefit from it from the start, including but not limited to children, youth, families, and even co-designing those KM plans with these groups. It might be ideal to have a patient partner or a youth be the messenger to develop the resources, to review them, to identify strategies that might work with the groups. And how does it intersect with EDI-DI? Well, just as a couple of examples here, tailoring the key messages to specific groups, identifying strategies and evaluation methods that are going to be appropriate for different groups. So for example, if I was working with an Indigenous group, I might use a sharing circle instead of a policy dialogue. So just thinking about the context, thinking about the people that you're engaging with and what resonates with them, what they're, how they're used to receiving knowledge, processing knowledge, accepting knowledge, using knowledge. And then also equitably mobilizing and implementing knowledge across groups. So we know that it's easier for some groups to access knowledge, to access resources. We want to make sure that we're reaching the people that need the knowledge, who can benefit from the knowledge, so that everyone has access to it and can benefit. So that's it for the KM, and I'll look forward to questions at the end.
Great, thank you, Stephanie. Yeah, you can definitely see how these topics are connected. So I'm now pleased to introduce Noma Delani, who's the director of the Children's Stroke Program at Sick Kids and associate professor in the Department of Pediatrics at the University of Toronto.
Thank you, Celia. And find my share slide function.
Hopefully at the bottom in the middle. If not, then Pierre may need to make you a co-host.
Yeah, found it.
Great.
Can you see my slides? Yes?
Yes, they look good.
Okay, thank you. So thank you so much, Celia, Pierre, and the team for having this training session today. And so I'll be speaking on behalf of the Equity, Diversity, Inclusion, Decolonization and Indigenization Program. And many thanks to Alex and Lorraine for their contributions to this presentation, but also just want to acknowledge Samadi and Zambia, who've also been had been very instrumental in supplying their thoughts and contributing to what I'm going to speak to next. And so as a brief outline, what I'll be talking about is the terminology that we use for EDI-DI, and just really rebase us in our definitions, many of which are known to you and known well, and then speak about the frameworks and principles of EDI-DI that we seek to adhere to and work within, and then let you know what we've been working on as a program. Can I just want everybody to mute themselves, please?
If I get permission from my...
Thanks. And so we just really wanted to start with our vision statement and, you know, our blue sky statement, which really wants to acknowledge that this is a journey, and a journey that we're all on. And despite the road looking straight, it very much is not. We know that it's windy, we know that it goes up and down and through various terrains, but the importance is that we're all looking towards a place and a space where health justice and health equity is achieved through the activities that we embark on, and by who we are and what we do towards a broader lens of social justice. And so really that is our overarching vision and theme. And so I just want us to always remember that there isn't really a one approach fits all to this. There isn't really a straight road to this, and we're learning all the time how complex this space is, but it's a good thing. It's all about journeying, self-discovery, as well as discovering and learning more about each other. And so we know that within the context of this Child Right network, that what we seek to do, which is ultimately transform the lives of the families and children that we see and work with who have these brain-based developmental disorders. We want to transform their lives for the better, be part of that journey of improvement for them. And so we know that science is better when we are diverse and when it's inclusive, because it drives excellence, it drives creativity, and part of that is making sure that it is inclusive, so that the impact of what we're doing doesn't just affect small groups or those near and dear to us, but all and everyone. And so I know that this community is well versed in the concepts of equity and equality, and so I won't spend a lot of time talking about this, but in a real sort of graphic way, I think this nicely represents that equality is what we've often strived for in the past, thinking that if everybody gets the same, it's enough. But it isn't enough. We now understand better that we ought to be aiming at least for equity, where people get, and we all get what we need to succeed. But ultimately, we want justice in whichever spaces that we exist. And we are really working within a healthcare framework for the most part, but justice is also about removing those barriers. And I quite like this modification and adaptation of the three diagrammatic ones that I'm sure many of you have seen, but there are some subversive behaviors here, and you can see that it's not just about going over, it's not about nicely standing in a corner speaking, but sometimes you've got to pull things down and dismantle and disrupt. And I think this picture evokes that it's not always comfortable, it's not always easy, and it's certainly not passive. And so, those elements of EDI that we've mostly come to terms with and been growing in our understanding of are, I think, within closer reach for most of us. But thinking about decolonization and indigenization might be new for many of us here. And so, recognizing that we all have many shared experiences which are very relevant, and our intersectionality is a true human entity and speaks to the fact that we are all humans with mixed experiences and power dynamics based on our location and many other aspects. But there are certainly goals and objectives of Indigenous peoples that are different to those of BIPOC or other marginalized communities, and which very much refers to their sovereignty and their ownership and their history that is intricately related to this land. And so, one area of development for all of us that is necessary and part of the core priorities for this program is for us to understand decolonization, indigenization, take responsibility for our education therein, and be part of that process of, decolonization as mentioned, and indigenization. And so, those are our principles, EDI-DI, and importantly, we want to say the words and not get too used to using the acronyms. So equity, diversity, inclusion, decolonization, and indigenization. And then, what is that reflecting? And I go over to the right column, which is our values, our core values of respect, cultural humility, reciprocity, which is, exchange, listening and giving, being able to, have that two-way, three-way or more conversation and relationship and relationship building. The importance of reconciliation, so recognizing that we often not intentionally, but often unintentionally cause harm, and that there is a process by which there is reconciliation, and whether that's really because of or for something that we have been directly involved in or not, it's irrelevant. It's important for us all to be part of that, and empathy would be a core value, and ideally a core value for all of us. And so there is a lens that we look at things, and it's a human rights lens, Indigenous rights, disability rights, anti-Indigenous, anti-Black, anti-Black, anti-Asian racism, and always recognizing intersectionality, which would involve, recognizing and being very careful to acknowledge LGBTQ plus and Two-Spirit rights too. And so the breadth of the lenses that we look through really are best reflected through the concept of intersectionality, which really just tries to take into account everything, the power dynamics and the lack of power dynamics that we all share. And so, part of this process and our learning within the EDI program, EDI-DI program, as we've come into it, is recognizing the importance of partnership and community-based participatory partnership in particular, because we know that without this, it poses a real barrier to implementation science and knowledge mobilization. And so, what is the foundation, or what is the reason why these barriers exist? Well, there are historical as well as more recent reasons for people and patients and their caregivers to not trust us as healthcare professionals. And, as mentioned, these might be historical, but also quite current. There is also a lack of awareness related to the opportunity that research provides us, and the wariness of the added burden, because being involved in research is burdensome for those families that you know, we often want to engage in or engage with. Just to reduce any ambient noise that might come your way. Can you still hear me? Okay, great. And so, you know, that extra burden may also result from or cause financial barriers or loss of financial opportunities for many families. And then there are also cultural safety barriers. And so community-based participatory methodology will help us address these barriers, which are really very much related to principles of equity, diversity, inclusion, decolonization, and indigenization. And so what have we been working on as a program? So, you know, really from the very beginning, we've been aware of the need for there to be an environmental and cultural shift. The way that we interact with each other, making sure that this is not just a safe place, but a brave space, providing people a framework to operate within, but also providing people with the support they need for their journey as they move through and self-realize, you know, any implicit biases, but also grow in the knowledge that will help us move this program and the broader program and in goals of Child Right forward. And so we've developed a strategic outline and implementation plan, which includes best practices. We are in the process of developing a learning pathway with a training team, as well as very much capacity building, which is a real core priority for us, as well as team development. So to this end, we are working on network-wide training, as well as trying to develop student mentorship opportunities at various levels and for all. Core to this is collaboration with other Child Right programs, as well as the ongoing research projects. Just continuing on what we've been working on, many of you are aware that we have been actually trying to facilitate improved education for all of us about Indigenous ways of being and appropriate ways of interacting with Indigenous peoples, as well as Indigenous health researchers, and how to best conduct Indigenous health research. We are currently engaging with potential Indigenous health researchers as well, to invite them to really partner with us in Child Right in leadership capacity, but also to help us form the equity, diversity, inclusion, decolonization and indigenization committees, which will support the work of the program. And so really ultimately what we aim to do is to continue to advance the research excellence by integrating EDI-DI into everything we do, so as to advance patient-oriented research. And so we acknowledge that this relationship building, which is foundational and core to everything that we're doing, takes time and needs to be done authentically. And so, you know, in summary, we are committed to shifting the culture within Child Right, not because it was a bad culture in any deliberate way, or any of us have been you know, behaving in an untoward way. It's just this journey of self-realization that we can do better, and by understanding each other's ways of being better, by centering those core values in everything we do, it will enhance our research, our engagement in research, as well as our knowledge mobilization, and allow us to implement the learnings from our research as we come upon them. We aim to do this by centering the voices of historically excluded people and their lived experiences in our work, and ensuring authentic inclusion of all people, including those with disabilities, to make sure that the connections that we create are both meaningful and sustainable. Thank you.
Great. Thank you very much, and I believe we are ahead of time on our schedule, which is great, because there's lots of content here. So I believe Noma needs to get going in a few minutes, but just wanted to open up for questions, particularly for Noma right now, while she's here, and then we will open it up for a broader Q&A session. And feel free to raise your hand or put your question in the chat as well, or if you have any comments, those are welcome as well. Well, I can start with one as people are thinking. So, just wondered what you thought some of the kind of opportunities were in this space, and some of the ways that you think it might be, some of the challenges that you think will need to be overcoming to think about equity, diversity, inclusion, decolonization, and indigenization within patient-oriented research.
So this is a bit of an abstract or maybe obtuse way of answering your question, but I think that the opportunity for education is a real opportunity because it will result in so much positive energy. It will create an environment for change, and it will really facilitate many of the aspects and of the work that we are seeking to do. So rather than seeing our lack of self-awareness or lack of environmental awareness as a negative thing, I think we like to reframe it as an opportunity to advance ourselves as well as the work. And I think the challenges are really the juxtaposition between what the current way that science needs us or wants us to operate, and what this space really requires. What we're learning is that this space requires time. If we're going to do it authentically, it requires a pace that allows us to do things authentically. It allows, you know, a pace that allows us to listen and learn and reflect and exchange ideas and go back and come back and say, okay, well, we have enough of this over here to do that aspect of work, but we don't have enough of that over there to do that aspect of work. And so we now need to capacity build over there, and we can push forward over here. And so it's complex and it's complicated, and it's, like I say, if it's going to be done, and I don't want to overuse the word authentic, but if it's going to be done authentically, it's going to require time and resources, both from a time and people point of view, but also financially. And often, you know, we have timelines and deliverables, and they're time pressured. And this really is quite a colonial way of thinking and colonial way of being. And it is the way we are all set up. And most of us accept this because that's how we're cultured. But it's a barrier to actually having true engagement and participation from the communities that we want to really be, you know, bring into the space. So I think that's a real challenge, and something that likely requires resources beyond the immediate. I don't really think these should be network specific resources, like that only network specific resources should be going into facilitating this kind of work. I am increasingly of the view that it really should be a political government ministry level priority that then provides the resources and the spaces to do the work.
Great, thank you. And I see that there is a comment in the chat, and Annette also has her up, so go ahead.
So do you want to answer Josh's first?
Only because I know Noma has to leave in a couple of minutes. Might just add that one. So if there's resources around EDI training for frontline clinicians working in community pediatric rehabilitation setup. So Noma, if there is any that you think of or anybody on this group, we can also send them around afterwards, and we'll have a few resources to share as well.
But I think this is one of the priorities of Child Bright moving forward, is to develop a resource, like access to different resources and further training. So, so it'd be important to sign up to our newsletter so that you can be made available, like as we develop these different tools, they'll be shared on the newsletter. And so anybody can have access to that, but knowing when they're ready and when they're available would be through the through our newsletter, I would say. So I also had a question for Noma, so if we could fit it in before she runs. So I really appreciate the concept of a learning pathway and the need for training that takes time and opportunities to really reflect. But I was wondering, this is sort of the intersection between EDI-DI training and knowledge mobilization, in the sense that, are there different ways of learning depending on who the target is? So these are very complex areas to learn about. And are the methods for our youth different than for health professionals, let's say in a rehab center, or for parents or for policymakers, just given the different potential targets and which methods might work best? So I was just wondering if there's been, if people have looked at this, if there's actually evidence around the best ways to educate different targets around EDI-DI.
I'm sure the answers to your questions are yes and yes, as in, I'm sure there are different approaches that are best for these different groups. And I expect people have looked at it. I just am not aware of that body of knowledge, but there may be others here who are. But it does remind me of something Harley spoke to, and I think maybe this is a broadly applicable principle, and that he has, I think, I have to do the math, 70-20-10 maybe model of learning, and something like 10% of it is didactic, 20% of it, might be, again, learned from different spaces, but the majority is self-motivated, self-driven, and to some extent experiential. And so, yes, there is the outreach aspects and the role that we would have to facilitate education, but I think what that speaks to is that will only ever go so far in actually changing our behaviors. And there's that sort of old knowledge, attitude and behavior view of things, whereby going from knowledge to changing behavior is not straightforward, and it seems increasingly to depend on how much we're invested at a personal level, how much we care at a personal level, and how much we're prepared to do ourselves at a personal level.
All right. Well, thank you, Noma. I'm assuming you have to head off. I'd like to welcome Stephanie and Janet back to the floor. And maybe, Pierre, if you can take the slides down, we can see everybody and have a bit of a conversation. And I will turn it over to you, Pierre, to facilitate the Q&A. You're muted.
It's only been 2 years of using Zoom, but here we are. Thank you so much. Thank you, Noma, for joining. Right, so yeah, happy to field more questions for Stephanie and Janet for your implementation science or knowledge mobilization specific questions. But I do want to mention we do have Lorraine here as well, our director of Child Bright, who will happy to take some additional EDI-DI questions if you do have them. All right, so yeah, feel free to raise your hand or just continue on and input your question in the chat box. So I'm seeing that Michelle has a question. or I guess a comment and a question. So tagging along with Noma's sharing about organic and authentic processes in KMN in conflict with rigid timelines and budgetary limits for, I guess this is direct to both Stephanie and Janet. Can you share an experience where you renegotiated these limits? Were the funders or principal organization open to flexibility, or able to incorporate those more realistic goals given some of these extraneous limits that would be on your work?
I can speak to that. I've experienced flexibility and lack of flexibility. It depends on the funder or the partner in large part. I would recommend starting as early as possible in a project to make establish those relationships and work towards timelines. And of course, with pandemics and organizational processes and cultural differences, all of these things can change the required timeline. I mean, even a no-cost extension, will enable you to use those funds later to carry out the plans that you might have had, or require also you to adapt them given the constraints. So it's never ideal, but I do agree that it's very important to consider that and to increase awareness to funders about the need for this, so that you can do KM or even the project in the right way, in a good way, with your partners.
And just to build on that, those points, and to address Annette's question and what Noma had shared with us, the idea of taking a participatory approach and using co-design methods to work with our end users to help us throughout the research process, starting with even co-developing the question and co-designing interventions, and then identifying what are the important outcomes to these end users. All of those things contribute to, I think, having successful implementation outcomes. But to Stephanie's point, that takes time. And so what we, I think, together as a network want to share is that importance of starting early to build those relationships. I've experienced, I'm sure many of you have experienced, other researchers coming to me when it's grant time to say, how did you get your knowledge users, and how did you get your patient partners, and is there some I can use? And from an ethical standpoint, these are questions that we struggle with as researchers who are seeking funding to support our work. My patient partners and the parents who work with me, I've been working with them for 10 years. And it's a partnership that has grown over time. And so for any new young investigators who are on the call, I would encourage you to start now in building these partnerships and relationships with children and youth and parents, as well as other stakeholder partners. So I'll stop there.
Thank you, Jen. I just want to I'm sharing in the chat with you an upcoming session that we are organizing in a few weeks. It won't touch on all of those restraints, but we'll primarily be focusing on the budget question and sort of what that takes to ensure that you do have this sort of fair and equitable approach to the work that you do. And yeah, I think it's important what you all are mentioning in terms of, it's critical that that process be started early, and it's not something you tag on at the end. So Annette, I see you have your hand up.
Yeah, so just it really reminds me of the unexpected prolongation of timelines in doing patient-oriented research. So when we began in 2016, with all our best of intentions, we had a small pool of patient partners, and most of our researchers have never done patient-oriented research. And we only had a small number of patient partners, whether mostly parents, who had participated as research partners. So we had a lot to learn. And so the process of developing, co-building the protocols and determining all the elements from the question to the recruitment strategies, the interventions, the outcome measures that matter, and so forth, took us way more time than we expected, but it was worth it because we had a much better study that was much more relevant and much more likely to have an impact down the road. So building in those, like being realistic about the timelines in when you do the grant, always add a year more than you expect, because it does take more time to bring in different stakeholders into the discussion if you're really prepared to listen and learn. And there's that need for training. So we're now, we've come a long way in terms of our knowledge and experience in the conduct of patient-oriented research. We have a much larger patient partner pool. We have close to 90 patient partners and over 20 youth with disabilities as partners. So, that's helpful, but now we're redirecting to some of these new areas, and we have to build capacity in these new areas and recognize that it doesn't happen overnight, and that's okay, as long as we continue to work together right from the onset.
Thank you, Annette. And Keiko, you had your hand up.
Yeah, those are excellent observations. It's so good to see this conversation growing and so many people interested. I wonder, I think it's more a reflection for the group, for everyone. I think one risk that we run is ignoring who is not at the table, right? And that's the EDI considerations, that it's so important. As Annette said, like, we came a long way in building the infrastructure, the resources, the support, the capacity to include more patient partners, but we do know that there is a group that is not there, right? And those are hard to reach because our fault, like sometimes we're learning, right, how to be more inclusive of them. But even the methods and the process that have to be put in place now, as we consider more of this EDI-DI factors and into our thinking. And then in the relationships, as Janet mentioned so well, like a lot is on the relationships, and we tend to go to the partners that we already have good relationships with. So how to expand that circle, right? To make sure that people with whom we don't have relationships and that we're learning how to relate and how to include them in the entire research process. As we move forward, I think those will be important questions to be asked and explored.
Thank you, Keiko.
I had something to add to that, and also perhaps to respond to Tina's question in the chat. And that was around a gap that exists in funding. So when you are preparing grants, it's ideal, yes, to collaborate and co-develop that plan. And it can be challenging for people to clear their schedules and make themselves available and commit the time that is required for true engagement. And so what's missing is funding to compensate those individuals for their time so that they can engage in the grant development process. If you're a healthcare provider and you're collaborating, you kind of do it off the side of your desk during your workday between clinical things. If you're a researcher, you have funding for your salary, but patient partners don't, community partners don't. It's a big commitment for them, and we do want true engagement. And so that's one aspect that does need to change. And one other element that I might bring up here is around where the research questions come from. So if you're a researcher and you're putting your grant in, you want this to happen, and you're developing a proposal and then pulling people in to fill the gaps. An alternate approach is engaging with the people first, having them identify what the problem is or the questions are, and then moving forward that way. And this way they have the passion. This is the problem that they've identified, and you are there in a support role to facilitate the research process, and to do that in partnership. So two approaches that can help to mitigate the issue, but don't solve it.
Thank you, Stephanie. So any other thoughts or questions from the group or from the audience? I mean, feel free to reflect a bit more after the session. If you have any more questions, I have my email up in the next slide. And if you want to send them to me, I'll be happy to relay them to our panelists, and we'll work with them to get a response back to you. So with that said, and Annette, I just wanted to hand it. Oh, sorry, Celia, you have your hand up.
Oh, we can go on to Annette's. I had a question if we were keeping that going.
Okay, perfect. All right. So Annette just wanted to share a few wrap-up comments for us after the session today. So Annette, I'll hand the podium over to you.
Does Celia have a question though for the panel, or?
Yes.
Okay.
If we can
Okay, so we should
time to keep going. So I was just curious on because it's talking about the science of and actually implementing things. So what I've always kind of struggled a little bit with is some of maintaining that rigorous research in implementation, to know that it's there and it's advancing in that generalizable piece, with also working with people in the real world. And so thinking about these concepts that we have, how do you kind of, or like some tips for kind of balancing some of that rigor and strong research and the practical people that we're working with? It's a fairly broad and complicated question.
Well, I'll start with that, Stephanie, and you and Kate can jump in as well. But the way I see that very complicated question, Celia, is thinking about using theoretical frameworks to ground and guide your work, so that you're explicit about your plan, explicit about your program theory, so that it can be replicated by somebody else and challenged by other researchers. So that's one of the strategies that I would suggest we should adhere to help build the field and contribute to the field. As I mentioned, the variability that we face in the complexity of the health system creates so many challenges. So the transparent reporting, the using systematic approaches to assessing barriers and selecting interventions, all of those things help us to contribute to a more generalizable database, if you will.
I would echo Janet's comments about using theoretical frameworks and documenting what's happening. I mean, there are frameworks for tracking adaptations to your plan as well, right? So you're being transparent about reporting how you've adapted based on, potentially changing barriers and facilitators as you go through the course of your project. One thing that stuck with me was around what it is you're implementing. So if you're implementing a clinical intervention and you identify what the core components of that intervention are, your goal is to implement those core components, and the strategies that you use are going to be adapted based on the barriers, facilitators in a given context. So those are the things that can change, and it's the intervention itself, you're aiming for fidelity in that approach.
Just building on that a little bit, because I completely agree with those theories and models, but recognizing that some of them are like quite academic and complex, and trying to apply them with people that aren't used to that. Do you have any ways that you found that's been helpful to be able to apply these frameworks with people that aren't thinking about this every day, but still being able to kind of embed them within the work that we do in more of that kind of practical way, while we still know that we're based on that science? Any strategy?
Do you want to go first, Janet?
Yeah, sure. One strategy that I've used, Celia, is, again, and this requires time and resources, but is the starting the process early, having continuous dialogue, open dialogue with my stakeholder group about the framework, breaking it down into everyday language, having them actually describe for me how they interpret the components of the framework, the relevance of the framework, what they see as missing in relation to the problem that we're trying to address. So it is that constant engagement that you need throughout the process, and trying to bring the framework down to a more usable, understandable level, taking the jargon out and using everyday language and everyday words to describe that.
Yeah, I do the same thing. I use different frameworks for different purposes, and so a process framework is something that I would, be engaging the partners in, and the same thing, explaining how it's working. And then, I don't need to pull out the adaptability framework and describe to them what category of adaptation this falls under. That's not going to be practical. So a lot of it happens behind the scenes, and then you're sharing that, learning that knowledge, the process, the outcomes in plain language, or using the language that that those groups are using.
And I've just put in the chat if there are people on the call that were interested in, like what Stephanie said around process models and the different types of theories, models, and frameworks, because it can be incredibly overwhelming to have all of those different ones. So I find that website can be helpful to break it down into what are you asking, what kind of framework might be helpful, and giving you a few options when you're starting to think through the kind of next steps. And I also see a few people on the call that I think probably have experience with this area, so hoping that others might jump in and share their thoughts or strategies on how they've been able to work in that area.
Mhm. Any final comments or questions? So just as a wrap up, this session was really meant to introduce these concepts of KM, IS, EDI-DI, so lots of acronyms, and introduce their definitions, some of the frameworks that are becoming available, but importantly, emphasizing why this is becoming so important in the conduct of childhood disability research, or research in general, as growing fields of science. So, we recognize that doing research is not sufficient to improving the health and healthcare of Canadians, that we have to be much more proactive to enable this knowledge to be taken up and used in ways that are appropriate and will help and improve child health. And also embedding EDI-DI in the work that we do as researchers and in our everyday lives will enhance participation, will enhance the reach and the relevance of our work. So, we're expecting this to have a very important impact on the work of Child Right moving forward. Another very important message was the importance of involving all relevant stakeholders right from the get-go, of doing and mobilizing and implementing research. And so considering not only those who are involved in generating the research, but also the potential knowledge users and the partners and allies. So these are people that can help push the agenda forward and enable the knowledge to be to actually be used in the health system. We will have future training sessions in the next year where we'll delve much deeper into these topics in terms of methods and strategies and how these concepts intersect with patient-oriented research. So I'm really pleased to see that there are people both within and outside the network that have participated today at the session. So for those who are not familiar with ChildBright, we're a pan-Canadian network that conducts patient-oriented research aimed at promoting brighter futures for children with brain-based developmental disabilities and their families. As a SPORE network, we have a large group of patient partners that are very engaged in all the facets of the network. But as we're looking into the future, we recognize that generating new knowledge is not sufficient to advance the health and healthcare of children. So it is important to mobilize and to study mobilize knowledge and to study the implementation strategies that can promote the uptake. So we're very interested as a network in learning more about KM and IS to put knowledge into action. We're also recognizing the importance of principles and practices of EDI-DI into our research efforts. And we appreciate that members will need to learn more about these concepts, and particularly how they intersect with our ChildBright activities. So we're very happy to host this session and begin this journey in learning more together and delving deeper as we move forward. We also recognize there's a need to build capacity in Canada in these areas of child health research with respect to KM, knowledge mobilization, implementation science, equity, diversity, inclusion, and indigeneity. So we're very fortunate to bring on to ChildBright some new leadership. So we're very pleased to have Celia Lauer, Janet Curran, Stephanie Glegg, and Noma Dlamini as new co-leads in our network to bring their expertise to these topics. So for those who are not part of ChildBright, I encourage you to sign up for our newsletter so you can learn more about the various opportunities, not only in training, but funding opportunities, involvement in committees where you have several new committees that are being organized in the near future that will be looking for different types of members. So I urge you to participate if you're interested. And thank you so much for your interest and your participation today.
Thank you, Annette. Yeah, I think that summed it up really nicely for the day. And I just wanted to pick up on what Annette was saying. We will be circulating a feedback survey for you just to get an impression of what you thought of the session today, but more importantly, to help identify what those gaps are in these various areas that you and your team face. And ideally, this would help us focus our training efforts and help develop content that would answer those questions and address those needs for project teams, and in so doing, develop that much needed capacity. So with that, thank you all again for joining us today and for sticking out to the end. And yeah, happy to field any questions, so feel free to send them to me by email, and we will certainly follow up in the next day or so with the feedback survey to you. And until then, take care, and I hope you will enjoy your upcoming long weekend. Take care. Bye.